was asking about lithophilus stadium. How is your practice about the typical
超滑导
lithophilus?
丝打了吗？混合超滑都行，对，可以打上来。
So Professor Wang now is beginning his operation. Hello, Professor Wang.
Hello, Professor Yu. Now
Yeah,
I'm on the table already.
Yes, we can see the video.
Can you see the endoscopic vision?
Yeah. We can see. So you can introduce now what are you doing?
Yes. Now inspect the left ureter with the standard ureter scope. So the ureter till now is not small. You can see. Now we have the stone here.
Yes.
Yes. So we try to push it upward, but it doesn't work. So I have to treat the patient in place.
With
Okay.
the semi-rigid uroscope or you will change the flexible uroscope?
Oh, okay. I'll change the flexible. Okay. Oh, great. I push the stone upward. And the mucosa of the upper ureter is a little bit inflammatory. Okay. Now advance fence sheath. Yes. 哦哇，OK，谢谢。打一个鞘1150的1150的，Yeah，负压平，激光接了吗？准备打激光。272。
Professor Wang, how big is the sheath that you're going to choose?
Yes, I'm going to choose 11 French, 11, 13 French, and
13, okay.
50 centimeters in length. Because the patient has done a PCL 9 years before, so that means equivalent to the patient has been pre-stented many years before. So just now we can see the caliber of the left side ureter is not small. So I choose 11, 13 French.
And what is your irrigation flow or pressure and suction pressure?
Irrigation flow 100 millimeters per minute in
100.
in the beginning. During the now I advance 20 meters, 25, 26. Okay, I'll stop here.
Yeah, the Professor Wang, you know we have the X-ray guided tell us when you stop put the ureter sheath, you know the stone was stuck in the ureter. Maybe if we put very deep or very maybe we are injury for the ureter cause the perforation.
Yes, that's a good question. You can see the urine from the ureter from the renal pelvic comes out through the sheath. Now it's clear. Just now the stone is not compact too much. Okay. So I just now I push back the stone into the renal pelvic. So for a compacted stone, I will I normally remember the the the, the length. I will calculate the length of of the ureter down the stone with the ureter scope. How much the ureter scope advanced into the ureter, and when I advance the sheath, I will not precede the length that the ureter scope entered just now.
Yeah,
No.
because the camera didn't show didn't see the your hands. Because I know when you retrieve your ureters the rigid ureter scopy, you will calculate the length from the urethral orifice to the stone the distance. So I think
Yes,
it's a very
yes,
very careful practice.
yes. That's the point. Uh, Normally speaking, to make a safe ureter scope, we should use a fluoroscope, fluor X-ray assistant with the X-ray
Yeah,
guidance. Yes, but nowadays we would like not use X-ray all the time. So I have to use the uh, direct vision guidance. Just
yeah,
as you see, I will inspect the stone, the ureter with the semi-rigid ureteroscope, and I will remember the length, how much the scope enters into the ureter, and when I push the advance the sheath, I will push it with the ureteroscope uh, direct vision guidance in the bladder to see how much the sheath enters into the ureter. Now here we are, we are in the renal pelvic already. Uh, the pressure of the irrigation is, let me see, uh, 15 millimeters mercury, 15, no,
yeah.
100, 100,
Low
yeah.
pressure.
Yeah, 来把这个拿掉，DOS wire，withdraw the wire 那我刚才讲
Professor
了，
Wang?
我有，yeah, yes,
Yes, and the temperature of the water that you're using, is it the room temperature water, or is it at 7 degrees, or
you mean how the room temperature is
the
now?
irrigation? Yeah, yes, the irrigation.
24 centigrade, 24 degrees Celsius.
Okay, okay,
Sometimes I prefer 25 or 26 because our patient is naked and we use a lot of irrigation may cause the hypo temperature of the patient.
oh,
Now you can see there the urine in the renal pelvic uh, is not so clear. So before I begin my fragmentation of the stone, I will uh, irrigate, to wash the renal pelvic, to flush the pus and dirty urine coming out.
This is a very useful skill. You know, many years ago, I learned this technique. You teach us when you're into the renal pelvis or into the bladder, let uh, the urine out. Maybe you can decrease the risk of the urinary infection.
Yes, just like now, when I see the stone in front of my eye, I'm excited. I couldn't help to treat it. Just like when I'm hungry and there is a sandwich, it's put aside. I'm not.
Yeah.
I should wash my hands first. And this stone may be the obstructed stone in the upper ureter, and I put it back just now from the upper ureter, and I use a scope try to scrub the blood clot away. And this is upper ureter, and this is the upper pole, the mid anterior calyx, mid posterior calyx. The stone situated here, and the mid lower anterior calyx, and this is the mid lower posterior calyx, and there are this is the another stones lies in the calyx. Now it's already clear. Will going to begin to treat the stones with the Thulium fiber from Raykeen.
Yeah, I have a question for the Professor Wang and
Yes.
Professor Yu. Uh, do you think the flexible sheet and the flexible and also the small size flexible ureteroscopy can decrease the learning curve for the beginner who want to learn the fans, learn uh, the this kind of surgery?
Yes, Professor Yu, what's about your opinion?
We, you need to turn on the microphone. We can't hear your voice.
Okay, sorry. I think if you have the smaller flexible uroscope, you can choose the smaller one of the access sheaths. I think that the ratio of the uroscope and the access sheath is very important for decrease the pressure of the pelvis that maintain. And that is very important for the safety of this procedure. So if you have the smaller flexible ureterous scope, you can choose the smaller access sheath that can increase the one stage successful rate for beginner. Because at the beginning, you know, in China, for the most doctor, we don't use any X-ray for surveillance the step of the insertion access sheath. Just now you mentioned is hard to we don't know how deep. So maybe sometimes, maybe if you insert is too deep, maybe you make the injury of the kidney. So I told you I invented one product in the world. That is the access sheets with the video. You can see every
Okay.
detail. Yes, but it's unfortunately the company is full, so we cannot get the new products. I think that is very useful for the beginning for the beginner.
Yeah.
You can see some of the information. Maybe sometimes the ureter is too small,
Yeah.
or some you insert is too deep. So that is can provide the safety. Um, because in China there are so many patients. So I think for most doctor we don't use the X-ray free. So how to increase the safety? I think that is useful. And just another you said, I think smaller your scope maybe is for beginner is good choice. You can choose the smaller access sheets and maintain the good ratio of the your scope and the access sheets, especially for small stone. But if the stone is very
好，辅
big,
助桥。
maybe I suggest that you can do the procedures just like the pre-stents.
Yeah.
If pre-stent is very useful, I think it's very useful for beginner. If you have the 1 week or 2 week pre-stent, insert this procedure is very easy.
Okay.
Just know, it's very easy to complete this procedure. It's my opinion. We
Yeah.
can,
Very
yeah.
important recommendations.
Thank you. How about for Professor Wang? You can introduce your experience about this.
I would like to hear the opinion from New Zealand.
New Zealand, okay.
球踢出去呗。
Yeah, thank you. I guess on the point of we use a slightly different system, so we are lucky in that we have X-rays for all of our operations. And so I agree that learning curve for putting in a access sheath is difficult if you don't have some feedback in terms of how hard to push.
Yeah.
It's a difficult way to learn if every time you make a mistake you're causing a stricture where you can't do the operation or you have bleeding, for the patient. I was interested to hear about the video access sheath of Dr. Yu. I think that's a great idea. But for us, it's we're lucky because we can see on the X-ray the sheath go up, and so you can see whether the sheath can go up the distal ureter. You can see how far the sheath goes up as well, and often you can see where the stone is. So the chance of perforating the ureter as you're putting the sheath is much lower. I do think the suction sheath is harder to learn. It's much more difficult to perform, I think, because you're moving the sheath and the scope at the same time, and there's more to think about in terms of irrigation and suction pressures. Whereas before, you just have to learn to put a scope into the kidney and laser. But that's been my experience.
I never do the I never use the sheet with suction. I don't know the pressure, the suction pressure can is there any or the machine can chew or you need to the people can chew the suction pressure.
Yeah, so I think in China now, a lot of units will have, an automatic machine and a pump.
Yeah.
And in Asia, predominantly, people are using the pump. But in the West, I believe in America, Europe, and certainly with us, we don't have a pump yet. And so we're a little bit old school. We use a pressure bag.
Oh yeah.
On the fluid. It's 10 years, 15-year technology. But the problem with the pressure bag is two problems I find. One is you don't actually know what pressure is going through. And so, and as the bag empties, the pressure decreases. But the pressure bag is not clear, so the nurses can't see how much water is left.
Yeah,
So it's very difficult to control. And so it takes a lot of experience to know when the pressure is fast or slow. It's like when you're doing a nucleation and you're running out of fluid and you know you're running out of fluid because it becomes a bit more red. And you tell the nurses say, no, there's plenty of fluid, but it's not right. But that takes experience.
yeah, it's
But
not
now
a,
we're trying to get the pump.
okay. I think it's not a accurate thing because you when you do surgery, you it will divide your focusing
Yes.
time to, well, there's an out of irrigation. Oh wow, the
Yeah.
pressure bag is no pressure. So I think maybe in the future we need a machine who can help us monitor the pressure.
Absolutely. I mean, the
Yes,
machines are out there. It's just expensive.
I think not so many factory can produce these
Yeah.
products.
Yeah,
The new generation of the machine, we can moderate the
the
pressure
pressure.
in the pelvis. And I think if you because at the beginning we always use the palm. I think that
Yeah.
depends on the experience of the surgeon.
Okay.
For suction exercises, you can see you just we depend on the space of the pelvis. So we maintain the space not too big or not too small. If the space is too small, that means the suction is too big because it's hard to lithotripsy the stone
Yes.
because maybe sometimes you will injure the mucosa. So we maintain the space in the mild space, I think is okay. And if the space is too large, that means that the pressure is too high.
Yeah.
So at first, we just depend on the experience of the surgeon. And I think there are so many choices. We can monitor in the pressure, and sometimes we can monitor in the temperature. So that means the machine can test, can monitor the pressure and can adjust the irrigation intelligent. So that is automatically. I think that machine can provide more safety for the patient and for doctor.
Yeah. And also I have another interesting question. Is maybe 2 weeks ago I heard one colleague told me, oh, he do one surgery like the flexible ureteroscopy lithotripsy cost 4 hours. So I want to ask you, what's the longest time for you when you do the flexible lithotripsy, and what's the limited time for you when you do this kind of surgery? You allow the your assistant to do this kind of surgery.
Maybe Professor Wang can give us the answer. What is the correct answer?
You know we have
Yes,
the
I
sections
know.
here. Maybe
Yes.
we can allow
Uh,
more longer time.
Before we have the fence technique. There is a consensus in China, or maybe widely accepted worldwide, that uh, the limitation of a ureteroscope procedure uh, is 90 minutes. But with the fence
90 minutes.
technique, yes, 90. Uh,
90 years,
yes,
1.5 hours. Yeah.
yes. After we have fence technique, the limit is expand. Maybe it's safe is 120 2 hours. Within 2 hours, sometimes we there is some new studies shows that many doctors try to treat bigger stones larger than centimeters or 3 centimeters in size uh, with a fence technique. and it is time consuming.
Yeah.
Sometimes it will take more than 2 hours. Some
Yeah.
doctors even try to do bigger stones in 3 to 4 hours. There is
Yeah.
some reported cases in the literature. So the fence
Yeah, I
technique give us
yes.
a safe protection. It has two advantages compared to the uh, previous technique. First, we will have a low pressure in the renal pelvic, so it will cause less extravasation or less fluid uh, absorption. So we have less inflammation complications. And the second, because the vision during the procedure is very clear, so the and the suction technique and the bendable tip of the sheath provides us uh, to give the patient a higher stone-free rate. Uh, in the These are two advantages of the fence technique. Professor Yu?
Yes, I totally agree with the Professor Wang, because in China, so maybe some doctor have some special device. They can monitoring the pelvis. So they said there's no limitation for operation time. But I think for most patient, most doctor in especially in big center, um, they disagree with this opinion, because I totally agree with the Professor Wang. In our center, for just especially for our group, maybe I think 90 millimeter minute, I think is suitable for most cases. And I think if the stone is very big, you have two choices. One is the staged surgeries. Another choice, you can perform the PCNL. I think for most cases, PCNL is very safe. So just it depends on the communication with the patient. I think the safety is the most important for stone surgery. So in our hospital, my our director said, if you do this procedure for a long time, not means the surgeon is very smart. That means this surgeon is very brave. So that's our opinion. I think the safety is the most important. So I
Yeah,
think a long time work is not comfortable for the surgeon. So both for surgeon and for patient is not good. So I think maybe 2 hours is the limitation.
Yeah.
Is for most stone doctor.
So I think the PCN scale is necessary for a stone
Yes.
disease doctor. I think maybe sometimes we need this traditional technique to help us.
Yes.
Because I didn't learn the technical PCNL. I think it's more complex than the fans than the flexible urethral lithotripsy. So and also it's a ridiculous phenomenon. Some colleagues said in the hospital they never do the PCNL. They just do the flexible ureteroscopy. I think why they said, oh, the PCNL is dangerous. They maybe have a bleeding problem and also have some other problem. But as you said, the PCNL maybe it's a necessary skill for any stone disease doctor.
I think PCL, and this technique is very important, not just for stone doctor, and
Yeah,
I
yeah,
think it's for
hydronephrosis.
Yeah. Because if the kidney have the hydronephrosis,
Yeah,
I think this technique is very important.
yeah,
So you can have the drainage from the kidney. So that is very important. So in China, I think that is different, totally different with the other countries. We perform most doctor performed this procedure just guided by the ultrasound.
yeah.
So that's very easy to grasp. You just know uh, which is the kidney. This one, and then another one. You will know the shape of the hydronephrosis. You will locate the calyx, the top of the calyx. You just puncture
Yeah,
to this and insert the guide wire and under the uh, guided of the ultrasound you can see whole procedure of the puncture. But I think the most difficult step is dilation because in China almost no one used the X-ray. So dilation just depends on your experience, your feeling of the hand, just like you insert the excess sheath. So
yeah,
I think that is the most difficult steps. So another step is very easy. So I think some communication for PCL techniques, everyone can grasp this technique. Just you can just maybe um, several cases, you know the principle, and you try several cases, you will change your opinion. That is for most cases that is very safe and very useful.
yeah. And I don't know whether you do the UTUC tumor use the suction shell and the thulium laser. You use the thulium laser to do the ablation of the UTUC
Yes,
tumor. What Professor
I
Xu?
think Professor Wang,
Yes,
do you perform these cases?
yes, I do this to treat UTUC for more than 100 cases, and I
Wow,
think
many.
thulium laser is a good device to treat uh, uh, tumors in the renal pelvic. Before the thulium laser came into use, I normally use holmium laser to treat UTUC. For some simple cases, it may work, but for some large tumor, uh, it's sometimes may cause a mess. And because some UTUC may be bleeding, and the holmium laser has not very good effect of hemostasis. It's different. It's different from how to use a holmium laser to do a HOLEP to treat a BPH. It is more difficult for us to use a holmium laser to treat UTC. Uh, and now today we have thulium laser. It's a very good device to treat UTC because it has very great effect of hemostasis. Now,
Professor Wong,
Yes,
yeah,
what's the biggest tumor you treat with with a thulium laser?
uh, I choose according to the EU guideline. Uh, we can use laser to treat UTC for LLSS for low grade, uh, low grade,
Low grade superficial.
yes, smaller
Yep.
tumor and low grade, smaller than
oh great.
2 centimeters in length. And it not depends. It depends. It
Mm.
depends the differentiation of the tumor first. The second, the number of the tumor. And the third, the pedicle of the tumor. Last week I treat U2C with a longitudinal diameter more than 3 centimeters. But for that tumor, it is well differentiated with only small pedicle, maybe 5 millimeters in diameter. So I treat for this patient, I think maybe how the base of the tumor is the more important variant we should consider. Yeah.
So what was your technique for that? Do you ablate the top of for such a big tumor? Do you burn the top? You ablate the top and
before
then
I choose the
and then you cut
patient,
the bottom?
I will do give the patient do a CT scan with a delayed scan to show the renal pelvic very clearly. If I find the tumor may have a small small base, I would choose. I normally use that hormone blaster to cut. I will show you how I do it. For if the tumor is here, I will try to put the scope under the tumor and begin to
Oh, okay.
yeah, so
Yep.
to hit the base of the stone. Yeah,
like a enucleation.
Yeah, like a nucleation. One block
right?
and block incision. Yeah.
On block. Yeah.
You will divide the lesion into several pieces. And if the tumor is too large, how
yes, yes.
Can you
just now, the patient I mentioned just now, because after the tumor was incised with the Thulium laser, I cannot grasp it out. So I use a basket to basket the tumor piece by piece. It took more than at least 10 times withdrawal and to get the tumors out eventually. Yeah.
When you use flexible uroscope, access sheets, you can suction the small piece.
Yes, I use, of course. I only use suction sheets today, but it cannot work. Yeah.
It still is too big. Okay.
Yes, it's too big.
Yeah, because we have the suction sheet. In the past, some doctor and some patient may worry about if we divide the lesion into several pieces, it will increase the risk of the recurrence. In the renal pelvis if we cut the lesion into several pieces. But now we have the suction sheets. Maybe it will decrease the risk of recurrence.
Yes. So I have a question. So what the information of the patient you will choose this treatment? Because for the standard treatment we need to perform the nephrectomy. So just depends on the size of the tumor, or depends on the opinion of the patient or other requirements.
According to the technique advancement.
Yes.
In generally speaking, traditionally we do radical nephrectomy, nephrectomy and ureterectomy for UTUC, because we cannot do this technique endoscopically. And but for UTUC, it is different from that of TCC in bladder, because for bladder tumors, more than 90% of blood tumors are superficial. But for UTUC, 2/3 of them are the stage of the UTUC is bigger, is upper than 2 PT2A. So for most patients, UTUC patients, we do RNU traditionally. But today we have this endoscopic technique. We can choose the small tumors, well differentiated, not TA, TIS, or even T1 UTUC to treat them in with the laser endoscopically. This is a recommended idea, recommendation with whether EAU guidelines.
The line.
Yes, it's already. Now, it's 4:30. I'm going to conclude my this procedure, and we
Remove all the
in the beginning the urethral stone is compacted here. After I treat the stone in the renal pelvic and treat the renal lower portcalyx stones already, I have inspected for many times. There's no residual stones in different all the calyx and the renal pelvic. And at last, I inspect the compacted site of the stone, because sometimes there are some metric stone or some small stones are embedded in the mural of the urethral wall. So I have to put all the small fragments out. So there's no stuff. The stone are all taken out. Just now I used the thulium laser to treat the stone. The energy set is 2 joules plus 330 hertz just now. So you can see the efficacy of the holmium laser, thulium laser fragmentation of the stone is very quick. And there's another good advantage of thulium laser is hemostasis. So just now we can see I sometimes hit the mucosa of the papilla of the pelvic of the renal calyx, but there's no bleeding. So I'm going to finish my procedure here, and thank you, Professor Yu, Professor Yuan, and Professor Said Mohammed, and Dalius. Thank you all for your participation of this Sino-African live surgery show, and thank you very much. Deputy State, 我拿支架. I will leave the stand for only 2 days. Yes.
Only 2 days.
Yes.
Because
that is
because
for most of people, patient, you just 2 days.
No. For the first time treating patient, if the ureter is dilated, I will leave the stent for 2 weeks or 3 weeks. And for a pre-stent patient, or for this patient, he has done the PCL previously, it means it has been pre-stented. So just now we saw the ureter is very good. So I leave the stent for only 2 days. I'll use the.
Do you leave a stent on a string? What?
假了，线呢？
Professor Wang?
来我前，Yeah，
How
那节
do
呢？
you do follow-up images for your patients? What kind of imaging would you do
哎，
and after how long?
嗯，
Yeah, all patients will do the KUB X-ray after on the post-operative day 1.
What about ultrasound or CT?
No,
When would
不
you
回答，
recommend that?
不回答，我着急
I
弄这
think
个
the
东西。
for the Professor Wang, he only use the X-ray
姐
and
姐忘了跟你
maybe
说
the
了，
ultrasound.
哦，
I really see the CT scan for the
那就弄吧，那
post-operative
拔吧，
only for the complex
反
case.
正说是说了，拔是拔了。
Did it scan?
You know, in some hospitals they
但我
will
看的是宽
do
的，
the CT
哦，技术重
regular
啊，
CT scan for the post-operative patient before the